The research question that this explored was, are HIV treatment programs being run by faith-based organizations experiencing a decline in funding or a flatlining in funding, and in consequence scaling back on their services? And you may wonder why this research was specifically focused on FBOs. Well, a study released in 2006 by the African Religious Health Assets Program showed that faith-based organizations are providing up to 70% of healthcare especially in rural areas, and especially in parts of sub-Saharan Africa. And this research specifically focused on Lesotho and Zambia. And the RHAP program has also explored religious health assets in a broader study released in 2008, which it showed the extent of funding of faith-based organizations. So to get along to the findings indicated that of the organizations interviewed, only 2 did not experience any funding shifts or flatlining, and the rest did indicate that. And the reasons were due to a number of factors, and I'll just list these in order of factors most commonly cited, in that order, which are donors' priorities shifting away from HIV, decline in funding due to the economic recession, funding shifting from civil society and faith-based organizations to governmental support, delay in funding for grants that have already been signed. The money's not arriving yet, although they've been promised the funds. And certain countries have lost funding entirely from specific donors because they are perceived as middle income, such as South Africa. I think I also had an example from Namibia. And the extent to which the effects of the flatlining included people being forced off treatment entirely or being delayed for a period of time and having to go off treatment and then start again, to also no new enrollees being allowed in treatment programs. Some organizations, although they had lost significant amount of money, they were able to replace some of the money, and so there's been a continuation of services. And I've already mentioned that 2 have not experienced any shift. And those interviewed also expressed how funding flatlining and decline has affected their other HIV and AIDS-related programmatic work, such as voluntary counseling and testing, access to CD4 counts and other lab tests, home-based care, social support, prevention, and support for orphans and vulnerable children, and also the impact on other HIV-related support services. So thank you.
Our 2 largest funders are the Global Fund and PEPFAR. The amount that PEPFAR is going to be cut is still up in the air. I'm kind of hearing rumors of about 20%, and that won't take effect until October 1st for us. The Global Fund immediately, as we were a recipient of the RCC, said, we know you submitted a budget, cut 10% right now, and we'll let you know how much more in the coming months. The mantra for these last 7 years, to me and many other faith-based organizations, is scale up, scale up, scale up, scale up. And, you know, I've lost a great deal of my own personal mental health in that process. And then within the last 6, months, all of a sudden it went from scale up to scale back. And with no guidance on how to do that. It is going to affect people. I can speak for Namibia, and I think it's certainly going to affect also the wider umbrella of services that people got that actually made Namibia one of the success countries, in terms of the numbers of women that access PMTCT. Well, they access PMTCT because there's 3,000 Catholic AIDS Action volunteers wandering villages with red T-shirts on, and as soon as they see a pregnant woman, they're going up to it, hey, do you know there's a medicine that can help your baby? And they're getting them into the clinic. So we're way over 85%. What's going to happen to that if there's no community mobilization for that? We also provide tremendous support for over 14,000 orphans. And as this cut comes, I'm asking the question, which child do I have to say no to? What's the criteria? Is it just the poorest kids? Do we do psychosocial assessment? Is it the HIV positive kids? Is it by geographical area? And the donors are saying, no, you're cut 20%, and my response is, then I need your help in scaling back those programs, and that's when there's just this deadening silence coming, from the donors.
Let me reflect a little bit on the reality of faith-based services, because it really is the faith-based services that have the longest history of being present with rural and remote areas in so many of the countries of the world, long before national programs were even ready to provide services. You will remember the colonial services was there to serve the elite or those that were workers in the system, so it was not really distributed out in the periphery. So that means particularly around the missions, there's been a tremendous effort to build up services that actually relate to the needs of people. And at that time, it was health services in whatever way one could contribute. A lot of the money now is pooled. In order not to have many funding agreements, in order to make the most efficient use of funding for well-coordinated services, Global Fund is one of them. At the country level, there are also these national pools of money, sector programs, whatever. So donors tend to like to put their money into those pools because they sit somewhere else and cannot so easily figure out where the money should go. The big problem is that some of these pools or some of the way of funding does not recognize and do not properly give space to the discussion of how one funds faith-based organizations. I'm not saying that to get out of the hook, but just to point out that there are some system issues here that one really needs to look at in order to make sure that it's access to services for people in the remote areas particularly, and continuity and quality of those services that should drive funding of those services. So where we see the kind of gaps and the kind of questions you raise, those discussions need to be local. They need to be relating to those funding mechanisms that's there. They need to be, a debate in the district, in the, with all, rather than owned by these services. There are some ways where faith-based groups communicate that does the opposite, that actually builds stigma rather than release people from stigma, that maybe hold on to barriers, that actually work against how one can prevent and live with HIV. So that's my comments. I think that this is therefore a piece of work that helps us raise those questions and probably engage with others, not just donors, but also how do we deal with these issues in the local community, in the district, in the nation, and globally. Thank you.
My name is Joe Fedora, Marino Magazine, the United States. Ambassador, I was at your presentation on AIDS and diplomacy, and you mentioned that great phrase, AIDS is no longer the flavor of the month, it's not even the flavor of the year. And so my question is, how do we make it, or how do you make it once more the flavor, if not of the month, at least of the year?
I'm not sure that we should make it the flavor of the month or the year, because it needs to be a long haul. So we need to mobilize the troops to sort of just make sure that this is not off the agenda. And maybe we can do more smart things by not being on the top of the agenda, because being in the limelight for a politician means simple solutions and quick results. And HIV isn't going to offer that. It needs the hard solutions and the compassion and the stability and being with people. And who else are better to accompany people in suffering year after year, communities in suffering, than the faith-based community? So here's even a strength. But let's not rely on the flavor of the month. Let's rely on the mobilization capacity and focusing on how this needs to be part of everything we're doing, because it cuts across absolutely every part of development and relations that we have in the world.